Hello, and thank you very much for giving me the opportunity to tell you about our new Pectus randomised controlled trial. Sorry I couldn't be there in person. My name's Joel Dunning. I'm a thoracic surgeon in Middlesbrough, and England has got together to create a study called Restore. But why are we in this position? Well, as you may know, in 2019, the NHS made a big mistake, forgot to look at the papers looking at cardiovascular compression in Pectus and took it off the NHS, which was a catastrophe. They actually only reviewed 12 papers. They literally forgot to put cardiovascular impairment in the search strategy. They thought it was a boob job for boys and they threw it out and made a massive mistake. We fought back, however. We had a patient called Autumn Bradley. We put her in the news. She had a Haller index of 10. She was short of breath, and yet she couldn't have her surgery. Our MPs took her case to Parliament, and we reopened the commissioning bid. We had a massive event in London with over 100 patients and people from all over the country. We even wrote a book called Pectus and Me, 41 accounts of patients suffering with Pectus, which is available for free online through the SCTS website. And most importantly, in our Pectus community, we created an international guideline with multiple societies, including CWIG, which I'm very grateful for. And this has been published recently in the European Journal. So as a result of this, we were given £1.9 million to do a study called Restore. And here are my co-investigators, led by Enoch Koa, a professor of cardiac surgery. So the background to this is that it can cause cardiovascular dysfunction as well as psychological impairment. Both are important, but the NHS is actually only interested in recommissioning cardiovascular impairment, so that is what they told us we had to do the study on. So therefore we are going to look at those, and they required us to do this in a randomised fashion. Now we did argue very strongly that, especially through the IDEAL collaboration group in Oxford that says you don't need to do randomised trials in surgery, that if you did all the tests before an op and all the tests after an op, that would be adequate, but they were not happy with that. They wanted a control group of untreated Pectus for a year to see if they'd get better, which to me still sounds crazy, and a lot of my patients sounds crazy, but that's where we're at. And then the other thing that they were really disappointed with the literature about, which they probably have a fair point, is that none of the literature shows whether the patients felt that they got better from a physical function point of view. So they told us they needed a patient related outcome measure, a patient reported outcome measure, not just a cardiopulmonary exercise test, because obviously getting better on an exercise bike doesn't mean you'll get better in your life. How strange. But that's our primary outcome measure. Now that scares the hell out of me and keeps me up at night, because this is our patient reported outcome measure. It's basically 10 questions, and they're not 10 questions designed for teenagers. So if you look down it, how many of my teenagers are going to be short of breath, bending, kneeling or stooping, or bathing or dressing yourself? So I think about, or lifting or carrying groceries. So I think 3 of these questions are not even going to get ticked at a low level. But things like vigorous or moderate activities, climbing stairs, some of our patients, will perform badly at this. And if we're going to get this back on the NHS, I've got to get an 11% improvement on average in this score. Now, the really pleasing thing is Dawn Jaruzelski in America has looked at cardiovascular symptoms in her cohort, and they do score badly. So I think we will get some bad scores beforehand. We've tried it out on 100 patients, and hopefully we will get better scores afterwards when we then retest them. So, of course, that's our primary outcome measure, but we will be doing a whole host of secondary outcome measures. Now, Frank in in Aarhus is doing a wonderful randomised study also in Pectus patients. I have to congratulate him for this outstanding achievement. He's going to randomise 120 patients just like us, but his primary outcome measure is going to be cardiopulmonary exercise test. Now, the guy's an incredible surgeon because before he was a surgeon, he was a physiologist, and also he did cardiopulmonary exercise testing for their Olympic team in the London Olympics. So there is nothing he doesn't know about CPET tests. You really need to talk to him because CPET tests are very problematic. There are a lot of things you can get wrong in a CPET test, which is why he's doing his study. And so basically, to cut a long story short, that's why it's not our primary outcome measure, because there's a lot of problems comparing different centres, problems comparing before and afters as people grow. If you do an operation at 16 and then compare it to their CPET when they're 19, there are big problems. There's even paediatric prediction scores versus adult prediction scores that you have to navigate through. So for a whole host of reasons, CPET is a secondary outcome measure in our study, but a very important one. We also were given not a single penny to look at psychological outcome measures in our study, but we're still going to have 6 psychological outcome measures. So we're going to have a depression anxiety score, HADS depression score, we're going to have the NUS questionnaire, the P-scapes from the Mayo Clinic, which is really very comprehensive, EQ5D, SF36, cost effectiveness analysis, and also a BIDS body dysmorphia score as well. So we are going to nail that question of, do you think you could make people feel better about themselves if you get rid of their pectus deformity, which again should be a slam dunk, but we want to do it properly, so it's in our trial. As I say, it's a randomised trial, but it was going to be just a pure randomised trial. But strangely, we showed the NHS some of the most horrific cases in the world, including a case report of a person that could lean on the right, breathe out, and occlude their IVC and make them pass out. And they could even do that in a cardiac MRI scanner. 2 cases of VF arrest, cases of arrests of patients having scoliosis surgery. So NHS England realised the massive mistake that they had made. So I'm really pleased, actually, that they then said we could have a national Pectus MDT in England. You're very welcome to join it. Anyone can join it. We have about 20 people, clinicians on it every single week. We discuss 7 cases. On that MDT, we have respiratory physiologists discussing the CPET. We have cardiologists discussing the echo. We've got lung function tests and the CT scan. And of course, surgeons presenting. And this is all the cases that are really super severe in the country, 7 a week. And we're now accepting people through an NHS pathway for people who the NHS really admit must have surgery. Now, obviously, that caused a big problem for our trial, because while we're going to offer to put these people in the randomised arm of the trial, effectively nobody's saying yes, because they've got their golden ticket. They can have their operation. The people that are saying yes in the randomised trial are those that cannot get surgery. So that is a big weakness of our trial, that it's a highly selected group of people that do have significant shortness of breath but don't qualify for the NHS England cohort group. But I'm pretty chilled about that personally, because we're going to have a cohort study, and the cohort study is all those patients being accepted by the NHS. And of course, the control group's all going to get surgery as well. So at the end of the day, we're going to turn into a big observational cohort study of 300 patients all having pectus surgery. Probably 24 centres. The whole study's 5 years, recruitment for 2 years. So as I say, big criticism of the trial. We are selective. It's not just anybody with any pectus. You've got to have a Haller index of over 3.25, and I hate the Haller index, and that's on end expiratory CT scan, and you have got to have significant shortness of breath. You've got to tick bad boxes on those 10 questions. There's no point if you get full marks on that, because I can't make you better. So you get rejected from the trial if you're not short of breath. There's a few other inclusion criteria, but basically if you're syncopal or having dysrhythmias, you're going to be significantly short of breath as well. So that's the main one. Very importantly, we are doing a pre-op scan in end expiration as well as end inspiration. We're measuring a whole load of indices because the HALA index is so terrible. We're measuring HELA, correction index, vertebral index, depression index, titanic index, asymmetry, and also the cardiac compression index and the cardiac asymmetry index. So we're going to try and hopefully find out what is the best index to predict our patients. Also, we absolutely mandate a post-op CT scan. That's our measure of quality. If you don't get the HALA index below 3.25, you haven't done a good operation. Ideally 2.5. But if you don't do post-op CT scans, you don't realise that actually you don't improve your patients all the way to normal. So I do encourage everybody here listening to this talk, do post-op CT scans for your own learning. Also, don't do them at 3 months. Do them before they leave your hospital if you can, because the operation's fresh in your mind, and if it's not quite as good as you thought, you'll learn for the next one. And here's an example picture you can see here. So the CT scan protocol, as I say, is end inspiration and end expiration. The HALA is 30% worse in end expiration in a lot of cases. In fact, I'm going to look in to see whether the change in your HALA index is actually a predictor of bad outcome, because some people it doesn't change much, and others it dips massively when they breathe out. And I think that in itself could be an interesting score, but we'll wait to see. And also of note, we mandate low dose non-contrast. This is super low radiation. It's about the same as 50 chest x-rays. This isn't the same as our thoracic surgery contrast high-res CT scans for cancer. It's about 100 times less radiation, so people can be very reassured that this is okay for patients. And we actually don't accept MRI scans because they're on gentle inspiration and expiration. It doesn't give you that full expiration. So here are all our measurements. As I've said, we've actually got an Excel spreadsheet, so if you were interested in recording some of these and working them out for yourself, we've got a clever little spreadsheet. You put all the numbers in, it spits out all these, so you can actually look at all these. And actually for me, the correction index is coming out really good, and the cardiac compression index is fascinating. It comes out abnormal far more commonly than I suspect, and I think will become a very important measure to decide if someone does have genuine cardiac compression. We got all our CPET physicians together and we discovered what Frank told us, that there is huge disparity in CPETs, and Dawn Jaruzelski told us this as well. She ignores every CPET done not at the Mayo, and the reason is that some do step protocols, some do ramp protocols, some do cycles, some do treadmill, some push them harder, some rest them different times. It's so different, it's crazy. Some just have different equipment. So we've tried to unify as much as possible. We're taking an exercise history because lots of them say, oh, is this deconditioning? So we want to know, do they exercise regularly? And we mandate it must be on a bike, it must be a ramp protocol coming up every 3 minutes. Ideally it's a ramp protocol of 30 watts a minute or a protocolized one according to their weight, and we document that, and it must be within a year of entry into the trial. And then we're going to do it at 1 year and 3 years for the early group, and we're going to do a second one before surgery in the late group, and 1 and 3 years. You've got to have FEV1 and FVC just before the test, so you've got a recent test to use as well. And importantly, the VO2 max, which is so important. When do you do it? Our CPET physicians were all varying. Do you do it as a single point, the highest one you find? Do you average the maximum value over 8 seconds, over 10 seconds, over 20 seconds, over 8 breaths? They had a massive fight about that, so it should be over at least 8 seconds. Obviously, when you're averaging that will drop the maximum value. So it's a really important thing to consider how your CPETs are done, and that makes a big difference to your VO2 max. So this is a few little slides on how the trial goes, but obviously you get in, you have surgery within 3 months. In the early arm and the late arm, you have it in more than a year, basically. And then you have a whole load of questionnaires, and we follow up for 5 years. Of note, the second CPET, so the last CPET at 3 years is 6 months after your bar comes out. So that, because it'll probably be maximal there. Of note, wonderful Frank in Aarhus is also doing a randomised trial of CPET before bar removal and CPET after bar removal to see how much of a difference it makes. So that'll be fascinating. And we're doing a little pilot just to make sure we hit our targets. We've already recruited and randomised 20, so we're well on target. And obviously in the UK we can accept people. They must have had all the 4 key tests before entry, and they do all their questionnaires, and in they go, which is great. We're spreading patients around the UK, so some centres might be low in patients, so where people are travelling, which doesn't seem to be a problem. And we've got some advice on the conduct of the NUS procedure. I've actually done a whole load of videos on my YouTube channel. Check them out. I've got an hour and 20 how to do it NUS procedure video by Dawn and myself videoing her operation. I've got an interview of how to do it. I've got a video of how to do the echo. I've got a video of how to do the CT scan measurements. So do check that out on my YouTube channel, Joel Dunning. Just write Joel Dunning Pectus and you will find it. But surgery can be done wrong. So if you look at the left-hand panel, that's the person that's had surgery. It's dipped at the bottom, and the third panel along shows you that one bar done in the middle can sometimes not be enough. It's too dipped at the bottom. So the far right one is a redo NUS in that person that then pushed it out properly, and that got their breathing back. Also, panel 2 is a crane, so please use a crane. But we don't mandate it in our study, but we gave these hints and tips. So that's the NUS procedure, a few hints and tips, cryo of course, and then a lot of you will be shocked to hear that we have the Ravitch procedure in the study as well. There are some older women and older people in their 30s and 40s that prefer the one-stop shop. Probably only about 10% of patients will have it, but we've also got hints and tips for it. Use big bars, use lots of bars, lots of plates, sorry. Lift everything, lift the ribs. You can't just hammock the sternum in the middle if the ribs are still dipping in, squashing the heart. A Ravitch procedure to get your breathing back is a very different procedure to a Ravitch to make you look better. And so here are some of our tips. Here are our sites. And here are some of our results. Dr. Claire Pryor is our patient representative and also one of our first patients. And we corrected her HALA of 8 to 2.7. This is Saida Mahima. Top left, you can see a sagittal image of her sternum 7 millimeters from her spine. And that's actually her IVC being compressed in the top left panel. And on the right is her post-op CT scans. This is Keris, who wanted a Ravitch. She wanted a one-stop shop. Top right is her pre-op, and bottom is some CT scans of her all fixed. And bottom right, you might just catch her Pectus penguin. Her grandmother stitched a Pectus into this penguin for psychological support during the operation, which I love. This is one of our other patients, and he recorded just a short video about his experiences.
Before the procedure, I was getting too tired and couldn't even go to school anymore. The dip in my chest made it so I couldn't go to the gym. And I was struggling to hang out with my mates as much. Since I've done it, since I've had the operation, I've been able to hang out with my friends every day, go to the gym every day, just being able to do a lot more stuff.
Thanks to him. So we do these little 3D recons, and I love these actually. These are really good. I actually do a little 3D recon at the start of surgery, and I actually send it to the patients, and then I give them the post-op one as well. Now this is a top tip from myself because it's free, and the app's called Scaniverse. Download it on your phone. You can do this for free. It costs no pence at all, and it's a great record to show to your patients and look back on before and after. Scaniverse. And so that's it really. So this was our very first patient that we got it back on the NHS and got the study going. Autumn Bradley at her graduation, feeling much better. And thank you very much for your support. I hope to report this trial in 3 years. We're going to do an early report to try and get back on the NHS, and then the full report will be available at 5 years. Thank you very much, and sorry I couldn't be there once again in person.